The caudal epidural steroid, we are entering through the sacral hiatus, and in fluoroscopy, when we are injecting the fluid, our needle tip has the lower border of the S2 vertebra. The problem comes with ultrasound is that whenever we are doing blocks with ultrasound, here we can see our needle tip is entering the sacral hiatus. We can see the tip is crossing the sacroiliac ligament, but we cannot see whether the needle tip is within a vessel or within any subarachnoid space. Okay, so it is not possible. So, what is the way out? So, the way out is in these areas, don't go too much inside. So, what we can do? We can stay a little below. For example, if you want to do an injection with the caudal epidural, so the sacral hiatus and under ultrasound. Under such a situation, what you can do, you can just pierce the sacrococcygeal ligament and without further entering, just switch on the Doppler and we can inject the jaw. So that is the difference between a fluoroscopy and ultrasound because whenever it goes deep, you cannot see all the structures clearly and the distribution cannot be seen because ultrasound don't have such a dye which can actually delineate which type of distribution it is. So let's start today's topic. Today we are going to discuss on three areas that we have already discussed under fluoroscopy. For example, what are those areas? One is the SI, one is the facet, and one is the caudal epidural. So under fluoroscopy, we were doing it for a long period of time since we started our practice in 2009, 2010, and then today even today, for the last 15 years, we're doing it under fluoroscopy. But for the last 5 years, certain procedures, for example, sacroiliac joint injection, piriformis injection. It has been found that with ultrasound, these procedures can be done more easily. That is why nowadays we do these blocks under the ultrasound guidance. Still, for the areas like facet, we sometimes prefer the fluoroscopy. Number one, we have a long practice of fluoroscopy. Number two, I have already stated in deep ultrasound is not as accurate as fluoroscopy. Let's start how to perform ultrasound guided caudal epidural steroid injection. Now the question is, in fluoroscopy and ultrasound, anatomy remains the same. It's not different. But what looking at anatomy becomes different. For example, if you look at the fluoroscopy, you might have seen the real image, what you see, not the normal or any cadaver or in a bone. The features that you can see almost the same with the fluoroscopy. But when we see the ultrasound, we cannot see all the structures. So in short, we sometimes say in fluoroscopy, we see the stems. If you're looking at a jungle, we see the stems in the fluoroscopy. And in ultrasound, we only see the superficial contour. For example, in the same way it is said, fluoroscopy shows you the stems, but ultrasound shows you the leaves. So here it is like that. We can see the undulation that is there. So whenever we are going to enter this area that is known as the sacral hiatus, so what we can see as a landmark is at this point, just above the coccyx, we want to see this structure. So how it will look. So for example, let me draw. So suppose we are putting the probe in this manner. We line. So we are putting the probe in this line. Okay. So when we are putting the probe in this manner, the undulation or bony margin that we will see will look like this. Huh? So what will happen? In one side, it will be like this. So it will be one chord. Then after the corner, there will be a flat area. And then again the chord. Okay. So it will be almost similar height. So the corner and in between a depression. And also there is another line will be there at the top. This is representing the sacrococcygeal ligaments. This area will be highly hyperechoic because of the bone. This area also will be hyperechoic and this area will be hyperechoic. In between, the echoes will move like this, and will show you this pattern. For example, let's clear all the drawings, and we are seeing at this point. For example, we are seeing over this point, over this area. Okay. Then how it will look? It will look something different. So how it will look? It will look like this, because there is no panel here. So this area will not be there. Only it will show posterior part of S3 vertebrae. We have understood how it will look. And now, if we put the probe in a long axis, for example, I'll show you. So if I put the probe like this, like a long axis, then how it will look? Then it will look like this. But in one area, one bone will be ending like this, the other bone will be starting like this. There will be acoustic shadow here, there will be acoustic shadow here, and there will be a clip like that. Also, we are having another buffering here. This is the sacrococcygeal ligament. So I've understood when we are putting the probe here, here, and above, how it looks. Now, accidentally, you are not exactly at the center, but you are paramedian. For example, you can show like this. So instead of putting it here, you are putting it at this point, at the corner. In that case, it will look like different. So let us draw you how it will look. In that case, it will look like this. There is a projection and then it is a stick. Okay. So remember, whenever you are exactly at the center, it will look like this. Okay. Whenever we are over a corner, it will look like this. If we go left, it will be over a corner. And usually it will be a little more posterior. It will not be exactly like this, but it will be like this. Because if we compare to this area, here at the center, it is ending here. In left and right side, it is ending little. It will look like this. I will show in the fluoroscopy, sorry, ultrasound demonstration. So how it will look. But anatomy is known to you all, so I'm not going to further discuss that. So here is the area that I have shown. Here we are seeing the cross-sectional view over the sacral hiatus. So as I told, this is left-sided corner, this is right-sided corner, and this portion is the posterior part of the body of the S4 and S5 vertebral body. And we can see another hyperechoic line at this point. Okay, so I am deleting it so that you can see. There is a hyperechoic line, and this line represents sacrococcygeal ligament, which is covering this area. Now, as I told, if we move slightly up, what will happen? In that case, the portion which is going below is gone, because now we are over the bone. Everything is under acoustic shadow. So we are at the top of the is three vertebral. If we go further down, so can you tell we are at the center or we are close to a corner in this picture I have demonstrated just now?
Center, sir.
Center.
Center. Is it really the center?
Little bit lateral.
Little bit lateral. That is correct. It is not at the center. We are examining, but this is not at the center because this projection is seen usually laterally, that I will show. And if we go exactly at the center, it will look like this. Okay. So in that case, the projected area that you can see, actually it's the corner. It is not there. So we can see the spines. Okay. And then this is the supraoxygeal ligament. And this is the stem when we are at the center. So we have understood that our aim is to go at the center, take a long axis view area. Now, at this sacral hiatus, first we have to take our entry point and we have to inject the local anesthetic at the entry point and a direct visualization into the skin and subcutaneous tissue. Once we have put the local anesthetic, next step will be putting an epidural needle. Okay. Now there is a question. Can I use a spinal needle? A number of physicians ask. But answer is yes, spinal needle can be used, but it has some problems. For example, epidural space is having a little bit more vascularity. There are epidural vessels. If you put a spinal needle, the chance of going inside the capillaries is more. And when we are doing it under the ultrasound, the problem is if it accidentally goes to the capillaries, you may not be able to detect that it is going to the capillaries. Now, why the spinal needle goes into the capillaries, but the epidural needles do not? Because capillaries are small. Now, whenever you are putting a spinal needle, usually you can go inside the capillaries. But whenever they are injecting it to a needle, usually the opening is at the side and also it is comparatively larger. So what happens? Usually, if it is close to the artery will move to one side. Sorry, not artery, but capillary. Capillary will either move to one side or it will simply break. So that is why we prefer using an epidural needle. So with help of ultrasound, we'll be putting our needle. We can all see the needle. We are putting the needle and we are crossing the sacrococcygeal ligament. Here we are touching the sacrococcygeal ligament and here we are crossing the sacrococcygeal ligament. If you do not have a fluoroscopy, you are doing solely ultrasound guided procedures. So your step here differs. If you are doing a solely ultrasound guided procedure, you don't have a fluoroscopy backup. So your first job will be switch on the Doppler, inject small volume of normal saline, like a test tube. Okay, so what will do? You will see the saline is not accumulated anywhere here. It is flowing smoothly. And when you are seeing under the Doppler, the echoes are moving like this. So this you will be able to see the echoes and when it is going behind the bone, from here the acoustic shadow will remain. You won't be able to see anything further. Only a Doppler signal moving like this is your way to find out that it is yes, it is going inside. That's all. And now there are studies that has shown that when we are doing following this technique, that is, we are just crossing the sacrococcygeal ligament, we are injecting under the direct Doppler. The success rate is quite high. It is above 90 or 95%. Exactly forgotten the studies, but it is almost over 90% correction. Now, if you are not happy with that, I want 100% surety like fluoroscopy. So what you can do? Now you have to change your path if you are doing an ultrasound assisted procedure. In that case, it will not be called an ultrasound guided procedure, rather ultrasound and fluoroscopy, or you can call it the hybrid procedure as well. After this, you have to do a lateral view and go further up to the S2 and the fluoroscopy, and then you have to give dye and check the dye spread. It will show the inverted factory appearance. And once you are getting the inverted factory appearance, you know it is epidural, it is not intrathecal, and it is very close to my target structure. So now you can inject the dimethyl prednisolone and steroid. If you are going up to the S2, then usual volume that is given is 10 ml for the last two vertebrae, that is the L5S1 and L45. At the same time, if you are doing under ultrasound, in that case, you might have to increase the volume. Usually 15 to 20 ml may be required if you are injecting from my nose. Ultrasound has disadvantages. You cannot go up. The volume goes up, but the concentration of the steroid remains the same. You cannot increase it up to over 80 milligram. If we do not want to 120 you can give, but it is usually not going to that level. 50 to 80 is the standard dose is given. So what happens? The concentration of the steroid reduces. So these are the problem that remains when we are doing on ultrasound. In case you have the hybrid technique, you can go for it and ultimately you can inject under the vision. So this is how you should complete it. Now regarding which one is better, fluoroscopy or ultrasound? I usually tell best is the hybrid technique because here we are getting the advantage of ultrasound because under the ultrasound guidance, as we are not drifting from the central plane, it is comparatively easy to put the needle in. But when it comes to the fluoroscopy, for the initially putting the needle in from the central line and maintaining the angle, you might have to change the direction, AP and lateral multiple times. It's not difficult, but it is more cumbersome compared to the ultrasound. So in this part, going to the sacrococcygeal ligament, ultrasound is super. But when it comes to going inside, here the ultrasound not remains as good as fluoroscopy. So let us see the video from which I have shown you the snaps basically. So here we are putting the needle. Now the needle is going inside. It is crossing the sacrococcygeal ligament. Okay. So now it has entered and then the angle is changed here. We have done a hybrid technique. So we have changed angle and then we moved up. And definitely after this, we have shifted to the fluoroscopy. The fluoroscopy images I have already shown to you. So do you have any questions regarding this procedure? I have not repeated the indications, the contraindications and everything because it is the same, whether it's fluoroscopy or ultrasound, it doesn't differ. Any
Uh,
question?
about
Yes.
the technique, is it an airplane needle trajectory or what?
Implant needle trajectory. When you can see, remember, implant means you have seen the whole length of the needle. It is going, you can see. So it is definitely an implant trajectory. Okay. An outer plane means your needle will look like a dot. And to find out the needle tip, you have to move up along the needle and to find out where it just vanishes. That is the extreme end or tip of the needle. Okay. Any other question? Dr. Ahmed, I've opened a mic. Please, no questions. Fine. So let's move to the next procedure. Our next procedure is such that here under ultrasound, we are getting a huge advantage, and nowadays almost all my sacroiliac joint injections are ultrasound guided. Don't do under fluoroscopy anymore. So, what is sacroiliac joint? We all know it's a diarthroidal joint and articular surface of the sacrum and ilium forming the joint. Upper part of the joint is mainly fibrous, whereas the lower part of joint is mainly synovial. When we inject at the lower part of the joint. Now, there are multiple coverings, or we can say there are multiple ligaments surrounding the joint. From the anterior side, we are having anterior sacroiliac ligament. From the posterior side, we have posterior sacroiliac ligament. Along with, there are two supporting ligaments, which actually divides the sciatic foramen into greater and lesser. One is the sacrospinous ligament, one is the sacrotuberous ligament. And sacroiliac joint can be osteopathic because of the age, because of the trauma, because of the degeneration, because of the different factors affecting the limb length or limb injury. So here we can see the anterior sacroiliac ligament. Here you can see the posterior sacroiliac ligament. And this ligament here is sacrotuberous ligament. So it is going to the ischial tuberosity to the sacrum. And the last but not the least, here we are having the sacrospinous ligament. So sacrotuberous and sacrospinous ligament is dividing this sciatic notch into sciatic foramens. And above the sacrospinous ligament, this area is the greater sciatic foramen. Below the this under the sacrotuberous and the sacrospinous ligament, it is the lesser sciatic foramen. So that we all know. So it is not very difficult. Question is, what are the structures at the top? And when we are going under the ultrasound, what the structures we will be able to see. Remember, we have some muscles which is surrounding this area, apart from the ligaments. So what are those muscles? So mainly there are three muscles. Together they are called the erector spinae. But there are three different muscles that we see at the tip. At the superficial, there is a like trapezius in the cervical area. We know it's a flat muscle covering whole the cervical area. In the similar way, in the lower part, we are having latissimus dorsi. That is another flat muscle that remains at the top of it. So at the top, you can see the latissimus dorsi layer, slightly lateral. We have the iliocostalis muscle layer, slightly medial. We have the longissimus muscle layer. Under the longissimus muscle layer, the deepmost muscle is the multifidus that is situated close to it. So these are the muscular layers, and just leave the latissimus dorsi alone. All other three muscles together are called the erector spinae group of muscles. Now, here also we have to look at the bony column. And one thing is very important that sometimes we see where is the lower part. Here there are two important areas. One, we have this one is PSIS. So here we can see posterior, superior, inferior spine. Okay. So this PSIS falls usually between the this one and these two foramina. Clear? And when it comes to the S3 foramina, slightly middle, at this area, actually the sacroiliac joint ends, and here you get the gap between the ischium and the sacrum. So our main target is close to the S2 foramina, either at the level of the S2 foramina or at the level between the S2 and S3 foramina, that you can see the joint base. Okay, usually S4 and S5 foramina is out. That means it is not within the sacroiliac joint level, it is below that level. So our target is at this point to look at the surface anatomy. So if we put the probe like this, for example, we are putting at the posterior superior iliac spine. In that case, what we will see at the posterior superior iliac spine, remember, PSIS usually falls between the S1 and S2 foramen. At the level of the PSIS, if we draw the margin, it will look like this. Okay. So first it will be the projection, pony projection. Then it will be the sacroiliac joint. Then it will be the posterior part of the sacrum. Then it is the sacral spine. It is the sacral spine of the opposite side. Then again the opposite side with sacroiliac joint. Okay. But at this portion, the overhang is too deep. So you have to always use the curvilinear probe because curvilinear probe shares the divergent beams. So the beam is not divergent, your beam will not enter. So you need a divergent beam, and that we can achieve with the curvilinear probe. Then some mucus will enter in the sacroiliac region. Now, from this area, if we come to this area, that means over S2 foramina. So the image will look like this. So one side, it will be showing you the ilium, then it will be showing the sacroiliac joint, then it will be showing the portion of the sacrum lateral to the S2 sacral foramina, and here it will show you the S2 sacral foramina, and then it will show you the sacral spine. So we understood clearly that this area, when you see this foramina and this foramina both, here we can inject, or we can go slightly below to this area and in between the S2 and S3. And at this area, what happens? This superior projection usually gets little flattened. Okay, it will not be such. It will be looking like this. And then we are having the sacroiliac joint. And as we are already crossed the S2 foramina, it will be a straight line, then spine, will be down. Usually we can inject at this point. Okay, so we have to know the surface anatomy, and based on the surface anatomy, we have to choose either at the level of the S2 foramina or in the area between S2 and S3 foramina and then inject. If you ask me, what you prefer at the level of the S2 foramina, slightly below the S2 foramen, I will always say it is slightly below the S2 foramen because there the overhang is also less. Also, I do not to think that accidentally if I go left or right, my needle will enter the S2 foramina. So I can easily inject from medial to lateral side. Remember, there are certain procedures where you have to put your needle from medial to lateral side, and sacroiliac joint is one of them. We have already seen under the fluoroscopy, we have done the same. We came from the medial side and then we injected to the medial to lateral side. Here also under fluoroscopy, we will be doing the same. So, what are the indications? Already discussed with the fluoroscopy. Not going to repeat. Contraindications exactly the same. Not going to discuss further twice. Now coming to the advantage. I have told you it is advantageous. What is the advantage? First of all, you can get rid of radiation. The joint is easily visible. There are no major vessels inside the joint. There are not much capillaries inside the joint. Aspiration is usually good enough to check, and it also reduces the risk of complications. You are doing under the ultrasound and it is doing in the bedside. You are avoiding the hazardous radiation and the needle is usually seen good. So if you are not able to see the needle, one thing you should remember, enter from a little more medial, because in fluoroscopy the shortest needle path is beneficial, because in that case you can put it easily, and that is what we commonly do in the panel view. But here we usually do not prefer a shorter needle path. Rather, if the needle is more angulated with the ultrasound probe, it will show you the needle much better. So that is the advantage. Limitations, definitely limitations are there. Arthrography you cannot do. Accidental intravascular detection, though the number of vessels are very less. With orthography, you got an advantage of the avoiding intravascular diastole. It will still not be there with the ultrasound. So here is the picture that you can see. Can anyone tell at which level it is? It is on the S2, below S2, or at the level of the posterior superior iliac spine? Please, any one of you.
Superior iliac spine.
It is at the level of the
Posterior superior iliac spine.
high posterior superior iliac spine. I have told you posterior superior iliac spine usually falls between S1 and S2. But here what we can see two depressions. Okay, let us show you. So what are those? I'm not getting this. Okay. Right. So you see in this area, you can see a projection. Then you can see the sacroiliac joint. Then you can see another dip here. Okay. So what is this? This is the S2. So it is at the level of the S2. Though by looking at this high peak, you might see it might appear you it is the posterior superior iliac spine, but usually posterior superior iliac spine do not falls at the level of the S2. It is not here. You can see clearly echoes are moving in. So it is the S2 foramina. It is the sacroiliac joint, and it is slightly below the posterior superior iliac spine. Now, if you move to the next part, so it is shown you. So it is the sacral foramina, sacrum. This is the sacroiliac joint and the iliac bone. And this is the needle direction when you are injecting. This is at the S2 level. I prefer going a little below the S2. So let us go and let us show you. And after this, we'll be discussing the facet. But any questions regarding this? No questions? I can tell you another thing regarding this, because you might be reading the Nisora website, Nisora books. So they usually do not use this posterior superior iliac spine as the main guide. Rather, they comes from below. So from where they comes? They usually comes from the sacral hiatus. From there they moves up in all the literature. They moves up at the sacroiliac joint. But I feel posterior iliac superior spine is a very good point, and we can palpate it clearly, and we can go there. But definitely, if you have any confusion, you can come from below as well. You can go to the sacral hiatus, then count the foramina up, and go at the level of the S2. So everything is very easy. You will be able to do it. Okay, let us go to the other room and let us show you how to form it. Okay, stop share. Somebody ক্যামেরাটা রোজ গন্ডগোল করে বলতে বলতে টায়ার্ড হয়ে গেছি কি ঠিক আছে কাঁপছে চলো সামনে ওইটা আমি ঠিক হচ্ছে এখন অসুবিধা হবে না তুমি যদি কথা বলো খুব কাজে লাগে So am I audible?
Yes, sir.
Hello?
Audible,
Okay.
sir.
With the SI? So we are starting with the SI, then we'll show you the caudal. So here, can you see this? So our first point for the SI is this part, that is the posterior superior iliac spine. So we'll first start scanning from here, then we'll gradually come down to the sacroiliac joint. So let us see what is the posterior superior iliac spine. Here I can get the and palpate the posterior superior iliac spine. So I am putting the probe over the posterior superior iliac spine. So one thing is that I have put in the opposite way. So let us correct it. So now we are in the correct way we are putting, because now the index marker is the left side. So left side of the screen is matching and with the left side of the patient. So here is the posterior superior iliac spine that we can see. Now in this area, we can see the layers of the muscles. So the deeper one is the multifidus, and superficially we are having two layers immediate superficially. One is the iliocostalis, one is the longissimus. Okay, so
Sir,
not
ca-
all are always
sir,
seen.
can you,
Hello.
sir, can you mark it by a pointer?
Yes, but remember, I will try to, but it is not always very clearly differentiated. That is why it is called as the same group. So I have to freeze it first. Just 1 second. Let me. No, no. Just, not engaged. This one? No, not that one, actually. Let's stop. So here, let us show the deepermost layer of muscle. This one, okay? This is the multifidus. This side is usually the longissimus, and this side remains the iliocostalis. And at the top, this muscle is the latissimus dorsi. And then we are having the skin and subcutaneous tissue. Okay, so this is the multifidus. This is the longissimus. This is the iliocostalis, and this is the latissimus dorsi. Okay. And here we can see this bony projection is the PSIS. So we understood what are the structures that we are seeing. But here, okay, from this area, now if we move up, okay, so now we are moving up, so we can see one foramina. Can everyone see some echoes are going through this? Okay, so this is the S1 foramina because PSIS usually falls between the S1 and S2. So from PSIS, if we move up, we'll go to the S1 foramina. Now, as we go down, again, we are at the level of the PSIS and we are not seeing the S1 or S2 foramina. We are directly over the sacrum, but it is a little bit upper part. So we have to come down. Now, as we come down, we start seeing another echo going in. Now, at this point, we can see some echo started going in. Please go ahead. Okay, can everyone see? There are two areas where echoes are going in. One is this one. Just 1 second. So one is this one, and the other is this one. Okay. So this area where the echoes are going in, this is the SI joint. Okay. These echoes are S2 foramina. Okay. So we can clearly see these are two echoes. So we are at the S2 level. Now there are certain literature that actually says that at this point you can come and you can put the needle like this and then we can go to the sacroiliac joint. Definitely you can go, but there is a chance that accidentally you might actually go and poke into the nerve. Though we do the S2 block, S1 blocks as well. So here it is not very problematic, but still, if you want a little more better way, like I usually prefer, is going slightly below. So from here, this is the S1. Now it is coming the S2. And now in this area, you see, after the S2 foramina, so you can see at the level of the S2 foramina. So we can see the S2 foramina now. Now at just we are crossing the S2 foramina, then another phenomenon usually takes place that this overhang of the sacroiliac joint is lost. Now we are just below the S2 foramina, please. Okay. And here, this area that we can see, here we are having one bone, that is the ilium. And here we are having the sacrum. We don't have any foramina here. And here easily we can come and we can inject like this from this side to this side. We can go and we can inject. So this is the simplest way to inject to the sacroiliac joint. Now, for those who follows Naisura or some other books, so it is also very simple. It is not difficult that you instead of moving from up, you go from down. So in that case, you ultimately will be going to the same area. You start from the sacral hiatus. So here you can see the sacral hiatus. Now you move up. Okay, from the sacral hiatus. Here it is closed. So here is till this is the hiatus. When it is closed, this is the S3. And now if we move up and go lateral, then we can see the sacroiliac joint. Okay. So here also in this way, we can find out the sacroiliac joint. So we are going to the same area. It's not different. Once we are moving up from opening of the sacral hiatus, once we are coming down from above. Okay. Everyone understood the sacroiliac joint? Anything else you want to see? You want to see how the sacrum, above the sacrum it looks, that I can also show. The central line. So usually with the lumbar, we'll discuss this part, that whether how to understand Virabhata. This is the central area. Okay. So this is the, and then we can go to the lateral side. Okay. So in this way, we can do a longitudinal scanning over the sacrum as well. But for doing the procedure, this much, this is not required. So it is over the foramen. So you can see foramens here. Some echoes are going in. So we are at the foraminal level now. But it's not required, because while doing procedures, we will not be requiring it. You have to use this technique of first going to the PSIS, finding out the S1, finding out the S2. Okay. And then here we are getting the area where you have to inject. Okay. Any questions? No questions. Fine. Everyone understood? Please, if anyone is having any doubt, please ask questions, because that is the only way to learn.
Sir,
Yes.
sir, my question is, hello.
Yes.
Sir, my
I
question is,
can.
when we are putting the needle, we are using we are using the spinal needle.
Here we are using a 22 gauge spinal needle, or if you want, you can use a echogenic needle as well.
Okay. And what is the feeling when we are entering the sacroiliac, lower part of the sacroiliac joint, sir?
So the feeling is, initially there will be a cutting feeling of the capsules, and then it will be a lost. That means a pop-up like thing. Okay, you are going inside the joint. So that feeling it will give. Okay, and then it will stuck in between the bones.
Okay.
Okay. So while taking out, you will get a resistance if it is stuck.
Thank you, sir.
Okay, another practical tip I can share you, that sometimes it might happen. See, SI joint is a very small joint. It can take only up to 2 ml or sometimes 2.5 ml of fluid. Sometimes even more, not that amount. So if you are not able to inject inside the SI joint the full amount of steroid that you have taken, usually we take 1.5 to 2 ml. But accidentally you have taken a little more, you are not able to inject inside, you can give pericapsular injection also. Remember, for the sacroiliac joint, sometimes the pericapsular injection also works. So in that way, initially you inject the maximum amount that you can inject within the joint without much resistance, and then come out slightly out of the capsule and inject the rest and then come. It will also work. Okay. So let's start with the caudal epidural steroid injection. So for the caudal, as it is much superficial, I will prefer a linear probe, not a curvilinear probe. So now I have taken a linear probe. So next one. And this side we can see the index marker. And now once I have determined which side in the index marker, I will keep the index marker towards the left side. And now as I am putting it exactly at the center, so I can see the sacral hiatus. Okay. So how to understand that I am at the level of the sacral hiatus? We can see the sacral cornus in both the sides. I can reduce the depth a little so that I can see it more clearly. Okay. So here we can see the sacral cornu both in the left side and the right side. So this is the left-sided sacral cornu. This is the left-sided sacral cornu. This is the right-sided sacral cornu. This is the posterior part of the body of the S4. I am a little hard, so it will be definitely S4. If I go further up, then it will be down, it will be the S5. And then here you can see some hyperechoic lines here, two hyperechoic lines, and then there is the hypoechoic area. So basically, this is the sacrococcygeal ligament. and below it is the opening, or this is actually the epidural space that is our target. Now, so at this point, you first get confirmed that you are at the center, you are at the opening. Now, once we are confirmed that we are here, so you can move a little up to check that whether it is, see, now we can see the S3 spine. So this portion is the S3 spine, okay? So it will not be as spinous as other spines, but it will be like this, S3 spine. Now we are going down and now the spine is gone, hiatus comes, and now if we go farther down, then the cornus will also end. So we can say at this point, the cornus are also will be ending. Then definitely we'll come to the coccyx area, but it will be uncomfortable for the volunteer not going further down. Now, from this point, we are now changed. Now changing the orientation of the probe, and now we are at a long axis view. So in the long axis view, we have to keep the center portion. Okay, I'm a little up, so I have to come down. So as I told you, here when I am at the center, I can see the picture like this. Now, if we move to the left lateral side, then you see, I start seeing the cornu at this point, okay? This is the cornu. And at the center, I can see the opening. If I go to the right side, again, I will start seeing the cornu. So, maintaining a central point. So, if you are lost, no issues. Come back. Got lost where I am. I'm not able to understand. So, come back and go and check that we are getting both the sacral cornus, and then we should rotate to 90 degree. And this is the area we can see the cornu, and you can come at the center. The cornu looks like a projection in one side, okay? And usually at the center, it will not be seen, okay? So this is one-sided cornu. The small projection we can see at the end of the cornu. So when we are at the cornu level, we will be able to see a small projection in one side, okay? But when we come to the center, it will be like this and this. So I'm especially highlighting this point of seeing the cornu here, because sometimes the new physicians actually get their needle stuck at the level of the cornu. Okay, so this is the right-sided cornu. Now I am coming at the center. Now also I can see one projection. So what is this projection? Can anyone tell? Everyone is silent. What is this projection? Just remind your anatomy.
Sacral cornu.
No, it is not the sacral cornu. Sacral cornu you have seen at this level. Just now I have seen a small cornu, but now it is much larger.
Hiatus.
Articular, sir,
No,
articular process of
no, it is not the articular process. It is not the cornu. Hiatus is here. Okay, this portion is hiatus. Okay, so this portion is very small. This portion is the hiatus. So what is this?
Spinous process.
I am at the midline. It is the spinous process of S3.
Yes, sir.
I have shown the same structure in the short axis view. Now I am showing the same structure in the long axis view. So I am sure it is an excellent area to now go to the sacroiliac joint. So I am showing you once again because I am not satisfied that you have not answered it. It is a very simple question I asked. Okay. So see, this is the cornu area. We can see small knob-like thing at the end. Now, when we are coming, this is the cornu exactly over the right cornu. Now, as I am coming down, I am coming to the middle part. Sorry. It was the left cornu, not the right cornu. Okay. So it was my mistake. So it was the right corner. Then this is the S3 spinous process. Then it is the left corner. Clear? Can you see? I am slightly to the left side, move towards the left so we can see the left corner. Can everyone see? I'm just pointing out here. And then from the left corner, if you go right, then it will come to the center line.
Please, sir, at the same level, make it a transverse scan so we can differentiate.
Okay, fine. So at the same level, I am making transverse. So here, if I make transverse, so we are expecting to see the S3 spine. So it is the transverse. Clear? This is the S3 spine. If you come down, then we'll see the again corner gap. Just try to make 3D anatomy into surface anatomy. Okay. So this is the projection. These are the corners. So when we go lateral, we see the corners. Whenever we are at the central line, and then we should do not see the corners. Okay. So again, I'm coming back. Okay. So it is at the center. We can see the spinous process of the S3. We can go lateral to see the right corner. We can see towards the right side of the screen. If I go towards the left, we can see the left corner at this point. So we are now at the center. Now, once we are at the center, then this is my target. Okay. So I have to put the needle under this view. Okay. So at this point, we can see the S3 spine, we can see the sacrococcygeal ligament, we can see the posterior part of the vertebral body of the S4 and S5. Okay, they are fused definitely. And now at this point, what is my first job? My first job is to put local anesthetic at this point. Okay. Once I have given local anesthetic at this point, then I will take the needle and from the needle I will enter and just cross the sacrococcygeal ligament and I will stop here after just crossing the sacrococcygeal ligament. Now you can go slightly more inside like this, but not much. Okay. Here. So once we are there, then we have to inject first a small volume to check that it is not collected here. Because initially giving a test volume 1 to 2 ml, because if it is collected at this point like this, okay, fluid is collected, that means I am superficial. I have to move my needle slightly down. Once we are seeing it is moving smoothly, and we have to switch on the Doppler as well, so that we can see the echoes are moving in this direction. Okay, the echoes are moving in this direction. Okay. So we can see the Doppler signals moving in this direction. That means it is going inside. Okay. And obviously you should be doing an aspiration as well to check whether you are accidentally within the vessel or not. But remember, as I told, if you are using a Tohei epidural needle, chances of getting a bloody tap is comparatively less. So everyone understood? Any questions?
Sir, are we going to feel the LOR similar like epidural in this case also?
Usually LOR is not done like the cervical or lumbar epidural when we are doing through the space. Usually we inject a dye here, mostly if you are doing under fluoroscopy. If you are under the ultrasound, usually we go for the test dose and aspiration. But LOR that typically we get in the lumbar and cervical area is not done here.
So, which is better, fluoroscopic or ultrasound guided?
I have told you, advantage of disadvantage of both. Putting the needle is much easier with the ultrasound. And confirming the needle at the end, it is much better with the fluoroscopy. So the best will be if you can use both the techniques, and next best will be probably the fluoroscopy, and third best will be the ultrasound. Okay, but still a number of physicians do it under ultrasound. The reason behind is, for a fluoroscopy shoot, you have to take the patient to the operation theater, or you have to take the patient to the cath lab, and which is sometimes is more difficult than doing it in the ward. So if someone decides to do the procedure in the ward, then it is comparatively easy to do under the ultrasound with the help of, without the help of the fluoroscopy.
Sir, when we are doing caudal ultrasound assisted and CM guided, then we have
Yes.
the 15 to 20 ml of volume.
In that case, you are moving up. If you in that case, you are going at the level of the lower border of the S2. And at this, when we are going at the level of the lower border of the S2, then usually 10 ml is good enough for lower two levels. If you want to reach higher levels, then you have to give more drug, but otherwise 15 ml, what is 10 to 15 ml or 15 to 20 ml, whatever we call it, at the lower part, that is not required.
Okay. Thank you.
Okay, fine. So next part will be the facet. So Dr. Roy will be saying about the facet joint, then I'll be showing the facet joint. Sure.
So, okay. Oh. So, okay. Next procedure is facet joint injection. So, facet joint injection. So, it is also, truly speaking, all the spine interventions, I always prefer fluoroscopy. Okay, over ultrasound, because ultrasound has a problem of, like intravascular injection, we cannot understand that whether we are going intravascularly or not, because that is the deadliest complication we can think of if particulate steroid goes inside a intravascular structure. So in fluoroscopy, it is very difficult, easy to understand by giving a contrast, but in ultrasound, it is not easy because we cannot give contrast. So anyway, when we are doing ultrasound guided facet joint injection, so mostly it is done for diagnostic medial branch block. So if you, of course, in intra-articular also, intra-articular joint injection also you can go for by this ultrasound guided injection. Okay, so and say in a case of facet joint arthropathy where you want to give diagnostic medial nerve block, there you are giving only local anesthetic. So that is if it goes intravascular also, that is not going to do much harm, and ultrasound will make the procedure as a office based procedure. It becomes very easy to do. Okay, so it has some advantages and some disadvantages. Okay, so you have to understand that where you want ultrasound guidance and where you want x-ray guidance. So anyway, indication remains same, whether you guidance you change remains, indication remains same. Indication is facet joint arthropathy or diagnostic block. So if it is a facet joint arthropathy and you are going intra-articular, so that is one procedure. And another procedure is you are targeting the medial branch. So mainly for diagnostic block, we will use the this ultrasound guided medial branch block. Okay, so two indications, so that if diagnostic is positive, so later we can go for radio frequency procedure. So in lumbar spine, so better to show you this one. So this is a 3D anatomy, just I show you so that you can understand the muscles. So what are the muscles here in lumbar spine, lower lumbar spine? So here the first muscle, it is the latissimus dorsi. So it is a very thin muscle here. So it is just under the skin, a very thin layer. So this is not that important muscle here. Here there are three other muscles which are around the lumbar spine. So one is paraspinal group of muscle. So paraspinal erector spiny group of muscle. So what are the erector spiny group of muscle? So there are one, this is the longissimus. If I hide it, then multifidus will come. Multifidus. So longissimus, multifidus, and this one is iliocostalis. Iliocostalis. These three muscles together is called erector spiny group of muscle. Okay. So this is one group of muscle which will be lying over the lumbar spine posteriorly. Okay. Now, if I hide these muscles, which are actually abdominal muscles, these are not important here. So I'm hiding this. So what other muscles are important? So posteriorly, I told you erector spiny muscles, and laterally, what is this muscle? This is called quadratus lumborum. If you see carefully, this is the quadratus lumborum, which is coming from the transverse processes. So these are the transverse process. Okay. So these are the transverse processes. From here, this quadratus lumborum comes. So this is another muscle. If I hide it, then anteriorly another muscle is there. So which is this muscle? This is iliopsoas. Here, of course, in this picture, psoas major minor written, but this is iliopsoas. Okay, psoas muscle. So this is lying anteriorly. If I hide them, though there are no other muscles. Okay, so then these small muscles are not much important, though intertransversary muscles are there. So these are in intertransversary muscles. These are intrinsic muscles. These are not much important. So you have to remember three groups of muscles around the lumbar spine. One is posterior, one is anterior, one is lateral. Why we need to know the muscles here? Because in ultrasound, we see the soft tissues mainly. Under the ultrasound beam doesn't go under the bone. So bony structures are also important, but then muscles also will see. So posteriorly erector spiny, laterally quadratus lumborum, anteriorly psoas major, iliopsoas. And now if I inject here, so you can see here also the same thing. You can see that this is like a Scotty dog only. So here what we will see this transverse process, we will see the superior articular process. So say I see this part, superior articular process, facet joint, inferior articular process, and then this is the lamina part. Lamina and spinous process is there in the middle part. Okay, if I hide it. Okay, spinous process in this middle part. This part is spinous process, lamina. So how it should look like? So if I put the probe, in this area, then how it will look? It will look a step-like thing. Okay, so this will represent the spinous process. Means in this middle part of the Scotty dog. Then this part will represent lamina. This part will represent the superior articular process. This superior articular process. Okay, superior articular process. And this part will be represented by transverse process. So this stepwise thing, you just remember that. So two areas are important here. So one is this step. So you will see these two steps. One is between lamina and spinous process. One is between transverse process and SAP. So why this step is important? Here is the location of medial branch. The same thing, just we will see in a different way. Okay. So, 4 views actually. We will see 4 views mainly for seeing the ultrasound of lumbar spine. So here it is the midline view. So midline view over the spinous processes. How it will look? It will look like this. So all the spinous processes, midline view. Okay. So this is a sagittal scan, long axis view, or sagittal scan, midline view. Okay. You can see this picture also. So L4, L5. Of course, sacrum is like this because sacrum there it is the normal spinous process is not there, and L5 S1 disc area or this part is a bit deeper. Okay. These parts are much superficial, these parts are much superficial, but this part is quite deep. Okay. So this is the midline view. In a long axis view, this is the midline view. Next view is over the lamina. So you have to understand what is the laminar view. So this is the laminar view. So what is the difference here? Difference, you understand that this part is very superficial, and from the skin we can palpate. When we give any I mean we want to palpate the spinous process, then we can palpate it. So we know this is much superficial, but we cannot palpate the lamina. So lamina is a bit deeper. So this distance will increase. This distance will increase from the bony margin. So in lumbar spine, bony margin is important. Okay. So this will look like, this is called horse head view. This will look like as horse head. Okay. You just imagine that there is a head. I mean, this is a horse. This is a horse. This is a horse. So this is a horse head view. Okay. So this is means over the lamina. So if this is a lamina, this is a lamina, then what is this space? What is this space? This is the paramedian interlaminar space. Okay. So we will show you the structures. So we can see the anterior in the paramedian interlaminar space. We can see the structures posterior dura and anterior the dural complex, posterior complex and anterior complex, both we can see. So here 2 lines we can see, one is dura, one is ligamentum flavum, and this side dura and posterior part of the vertebral body. So all these things we can see. So this is second view. So first view was over the spinous process, second view is over the lamina. Now we will see the third view. So what is the third view? Third view, we call it camel hump view. So what is camel hump view? So it is not as deep as the laminar view, but then the shape is a bit different. So here the laminar this camel hump view is, this is actually like this. This is actually not camel hump, but this upper one is camel hump view. So it will look like this, like this, like this. So why this view is like this? So this is due to the superior articular process. We are going over the superior articular process. So all superior articular process we are seeing. So we'll show it. So all the superior articular process we will see. So these are called this is called the camel hump view. So all these views will tell us that where is the location of our probe. So these are all long axis views. Okay. Now last view is fourth view is trident view. So what is that trident view? So when our probe is over the transverse process. So this transverse process, it will show only the acoustic shadows. It is like a trident. Okay. So you can imagine this trident like this, no? So this is called trident. So here also 3 views, 3 acoustic shadows. Okay, 3 acoustic shadows. So these are all transverse processes. So this is called a trident view. So this is also sagittal view. So there are 4 views we will see to understand the location of our probe. So where we have put in a sagittal section. One is in spinous view, midline spinous view. Second one is your laminar view. Third one is over the SAP or facet joints, over the SAP mainly. And fourth one is the over the transverse processes. First one, spinous view, only name is spinous view. Second is your lamina, over the lamina, it is called horse head view. Third one is called camel hump view. Fourth one is called trident view. Okay, so this will tell us the location of our probe in a longitudinal fashion. Now, if we put, so this probe, we have understood that we can put the probe over in a sagittal section in a longitudinal view. We can put the probe in a transverse view also. So either we can put it over the spinous process, or we can put between the spinous process. Okay, so what is the difference if we put over the spinous process or between the spinous process? So here, though it a bit changes with the position, if the kyphosis is there or not there, so structures may change a bit, but overall, when you are seeing this spinous process and lamina, so when you are putting a probe over here, so you will see this spinous process and lamina. So you will see basically this type of picture, mainly clearly. And the other part, this side you will not be seeing in that picture. Okay, so just a minute. Okay, so here, so this is the spinous process, and this part is lamina. Okay, spinous process, lamina. So you can see this is spinous process and this part is lamina. Here, of course, the this lamina should go and make, it should be continuous with the inferior articular process, and here there should be superior articular process. So there should be a facet joint here, and then in this way there should be a transverse process. Okay, it is there, but at a lower level. So that's why when I will come down, then I will see all these structures, but then I will not see the midline structure of spinous process and lamina. Of course, part of lamina will see, but not the other part. So here, when I am on the spinous process, we can see acoustic shadow of the spinous process and part of lamina. And this lamina, of course, it will end over the inferior articular process, but this view will show this much only. So this view shows some muscles. So what are the muscles? So these are the erector spiny group of muscles. I am not going in detail of which muscle is what, but it is the erector spiny group of muscles, three muscles. Okay, longissimus, multifidus, and iliocostalis. So this part, deep part is the multifidus. Above that, it is the longissimus, and iliocostalis is there in the laterally. So these muscles we can see. So all this area, actually whole this area is the erector spiny, because till the lamina is there, it is all erector spiny. We know that lumborum, quadratus lumborum starts from the transverse process. So above that, like posteriorly, everything is erector spiny. Now, in transverse process only, we are going a bit down when it is not over the spinous process. So what we are seeing here, so you can see the corresponding X-ray image also. So in this part, what we are seeing this is the transverse process. This is the transverse process. So here, yeah. So this is the transverse process, and this is the, of course, the erector spiny posterior dura is there, and this is the anterior complex is there. So this is the mainly intrathecal space. This is the intrathecal space. But of course, this picture is not good for just. So this picture is better. Yeah. So I'm showing when my probe is in the transverse position, but not in the midline. So what I am seeing here, so though this part is seen, so this is the lamina. Here also some part black is there, but this is actually not the complete spinous process. This is the mainly interspinous ligament also gives a shadow. But here it is the periosteum clearly seen. This is the lamina. And here another step, I can see another step. So what is this? This is the transverse process. Okay, this is the transverse process, and this part is actually SAP. This is the SAP, and this part I can see this is the IAP, inferior articular process. That means I have to search here for the joint space. So we'll show on the patient in a better way. So this is actually the joint space. So if I have to put a injection inside the joint, then my needle will come like this and it will go here. I make it red. Okay, it will come here. So it will go in the inside the joint intervention. For the intra-articular intervention, I will put the probe in this way and I will go here. So remember, for intervention, you have to see this step. This step is important. Okay, so when you see the step, you know this facet joint is here. Okay, and where is the medial branch? Medial branch is here. So if I want to put a medial branch injection, I will put the injection here. So here you can understand that when in the longitudinal this transverse section also, I can be on the transverse process and sometimes I can be between two transverse processes. That is possible. So when I will not see the bony acoustic shadow, then I will understand that I mean, when I will not see the periosteum and below the bony acoustic shadow, then I will know that I am in between the transverse process. And if I see the periosteal layer, then I know that I am on the transverse process. And as soon as transverse process ends, there is one muscle which starts. So this muscle is nothing but quadratus lumborum. So the above quadratus lumborum, everything is the erector spinae. Okay. So in this way, we will see the structures. Okay, so we'll see the structures. This is the intervention actually. So you can see the needle is coming. So this picture is not that good, but still, so this is the injection is coming intra-articularly here. Okay. So we'll see these structures for going inside the joint or on the medial branch. So we will see these pictures. Okay.
So for the facet joint, which type of probe we should take? Can anyone tell?
Linear, sir.
It's
Curvilinear.
curvilinear, yes. It's a deeper structure. So we have to be using the curvilinear probe. So first, I will be showing, it's a little bit of practice. Remember, facet is good to learn, but while doing, we still prefer the fluoroscopy. Because obvious regions it is deep, needle tip precision is not always good. So first, let us see the spine, how it looks. So reduce the depth. So which structure we are in? Over which structure we can see? Can anyone tell?
Laminar.
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 Lamina, yes, this is the Facet view. Okay. So we are paramedian. We are not at the center or we are not at the midline.
Spinous
Now
level.
excuse me. So when we are seeing horsehead, it means we are paramedian. We are over the lamina. We are not over the midline. Now, if you take the probe towards the midline, then all the structures, see, everything below will not be visible. We'll be only seeing the spinous processes. So we can see the spinous process. Here in this picture, we can see two spinous processes. Okay, so that is the first view, or that is known as the spinous process view. From the spinous process view, if you go slightly lateral, then depth increases and it looks exactly the head of an horse. This is the horsehead view or the laminar view. From there, if we move or tilt the probe slightly towards the medial side, then we'll be able to see the echoes going in. Okay, I can imagine. Here also it is there. Huh? Okay. So here at this position, we have not put the pillow below the abdomen. If we have put a pillow below the abdomen, it will be much more bigger. Okay. So, but still we can see. Okay. So these are the paramedian oblique view. So what is the importance of this paramedian oblique view? Can anyone tell?
We can see the anterior complex.
Yes, that's
Spinal
the
anesthesia we can mark for.
yes, spinal anesthesia as well as intralaminar epidural anesthesia. So can be done assisted definitely with this. Okay, intralaminar epidural that anesthesiologists do day and night, and that actually can be done if we do in the ultrasound assisted way. Now from here we are again coming back and we are going over the articular pillar. So here at the level where we are over the articular pillar, it will look like a camel hump. So this is the camel hump view. The first two camel hump are very, very clearly seen. Last one is also seen, but it is a little smaller. But anyway, these are the camel hump. So the bigger hump is actually the articular process, the top of the articular process, which is known as the mammillary body. And the smaller hump is the, yes, mammillary body. And here the smaller hump of the camel is actually the accessory body. That is another projection over the spine. So you can forget this, it is not that important, but we have to know the camel hump, we have to know the horse head. Now from the camel hump, if you go further lateral, okay, now we are moving further lateral. Now we can see another type of picture. So we can see these are the trident view, okay, or the finger-like projection view, okay. And in this view, we can see few structures. So what are these structures? This is the intratransverse complex. That includes the intratransverse lateralis ligament, intratransverse lateralis muscle, intratransverse ligament. And just under it, we can see the psoas muscle, okay? And after that, we are having the peritoneum. So peritoneum, we can see it will be moving with respiration. So if we come here and we can see the lowermost layer is moving with the respiration. Okay, so it is the peritoneum. Then we are having the layer of muscle, that is the psoas, and then further superficial to the trident, we have another layer, that is the erector spinae. So we have understood all layers of muscle. So this is what we see under the lateral view. If you move further lateral, okay, from here, if you move further lateral, then we'll see another muscle layer will appear. From here, it starts appearing. This is the quadratus lumborum layer. Okay. So those who are doing the QL blocks, okay, QL 1, 2, 3, 4. QL 4 actually is done for the pain physician, which is the intramuscular block that can be done by injecting inside this layer. Okay. Now the psoas is smaller, but QL is bigger. Now coming to the transverse positions, because for pain physicians, transverse position is important, because in transverse position, we see the spine, we see the just lateral to the spine, and both the sides, we can see the articular pillars. So what is 1? What is 2? What is 3?
One is spinous process.
2 is
laminar.
3.
3 transverse process.
1 is transverse process.
Transverse process.
Okay. Okay. And the 4 is, it is an arrow. Okay.
Superior articular.
These are the open articular pillar. So it is the junction of the superior articular process and the inferior articular process. Okay. And 5 is the position of the median process. Okay. So that is how we can find out. And here also When we are seeing this transverse process more clearly, we can see an acoustic shadow below. And here we can see two muscles. This muscle is the question mark. Which muscle is this? Attached to the lateral part of the
Quadratus lumborum.
transverse process?
Psoas.
No,
Psoas.
not psoas.
Quadratus lumborum.
Quadratus lumborum. And where is psoas? Psoas is under acoustic shadow now, but if we
Anteriorly.
move up, now we can see the psoas.
This
Okay?
is below the-
Because
Yes.
it is deep to the transverse process. So when I'm going to the intertransverse area, we start seeing the psoas muscle. When we are over the transverse process, there is acoustic shadow. The psoas, only small portion is visible, okay, in the lateral part. But here, when we go to the intertransverse area, now we are in the intertransverse area. Now we can see the psoas muscles. So now we can see all three muscles, okay? So erector spinae is at the back, quadratus lumborum, and also we can see the psoas muscle. Now, for the median branch block, we have to come like this. We have to come from the lateral side to over the transverse process like this. Okay. For the facet joint intra-articular injection, we have to find the open facet. So we can see the open facet at this point. Okay. So we have to come like this. Okay. Now it is open. Okay, we can see the cleft. So it will be like this for the facet. So that is how inject the medial branch and the intra-articular facet injections. So I think this is clear to everybody. Any questions?
Yes, sir.
Once more, can you show, sir?
Okay. So I am going back and just try to find out where is your transverse process. This is not the transverse process because we can see the psoas. Now, if we move up and down, see, here we started seeing the transverse process. So this is the junction. Okay. And just by the side, we can see the open facet as well. Okay. So that is the facet. Intra-articular facet will be given like this. And for the this one, for the median branch, you just find the transverse process and the superior part of the transverse process. So just from the intertransverse area, when we are reaching, this is the superior part of the transverse process. And the junction of the transverse process and with the lamina here is basically the area where you have to inject. So your needle will come like this area. Okay. This is the median branch and that is the facet. Okay.
Yes, sir.
Okay, so let's go to the quiz.com. Okay, just 1 second. You open the quiz.com. We are opening also. Just 1 second. Play now. Should come. Okay, please join.
Slow lion, jazz, surf,
Language
student,
আচ্ছা ঠিক আছে
Lena reader,
আচ্ছা কালকে কি কি আছে এখনো সকালে
a beta fiber, Y, SK,
এই দিকটা আগের দিন কাস্টমার আমাকে সেই দোকানে নিয়ে দিতে হতো বুঝেছি আগের দিন ওখানে এলো কত টাকা তুমি দিয়ে দিলে
brother snail,
ভুলে গেছি
Dr. Queen,
Okay, so let's start.
love steam, quiz nanometer joined, play and create,
which is an incorrect statement. Hypoechic sacrococcygeal ligament is never visible in this
Papa
view.
Hacker 1 joined.
What is drawn here by red color? Sacrococcygeal ligament. Which line is lateral sacral crest? One. Which sacral foramina is more likely here? S2. Which is false about USG guided SI joint block? Contralateral angulation is not required when USG is used. Which is true? Horsehead view. Which view is expected here? Camel hump view.
Final question. Double points.
What is not seen here? Spinous process.
The snail. Second place, SK. And the winner is Sir phone.
So, who is the third phone?
Dr. Neha.
Congratulations for being at the top. Two of the
Thank
study
you.
materials I have already shared. Only one part, the facet part is not there, but we'll be sharing that as well. Okay. And you will get the questions as well. Okay. So see this video again and again and also read. Okay. So let us end today.